Welcome back, Rebel EM listeners, to another episode of Rebel Crit. I'm your host or co-host, Frank Lodeserto, and I have my co-host with me,
Eric Acker. Sorry, I didn't get the cue there.
What are we working on today?
I wanted to do a quick recap. We are talking about the approach to a critically ill patient, these patients that you get called to the floor for a rapid response, or maybe you're just on the floor and your nurse is reaching out to you, worried about their current status. We've covered hypoxemia, we've covered tachypnea, so we still have a few other more topics to cover and work on. So I think next up is tachycardia.
Tachycardia. Yeah, let's be very specific about what we're going to talk about today. But just to reiterate what Dr. Acker was saying here, these shouldn't be addressed necessarily in isolation. When you're called to the bedside, who's someone who's hypoxemic, they may also be tachycardic. If they have increased work of breathing, tachypnea, they may also be tachycardic. So we're going to put all this together, I think, eventually, but we're tackling each vital sign separately, giving you algorithms for it, and then I think we're going to bring this together at some point, Eric. Is that right?
Yeah, we're going to go do some cases and work it out together and make sure we can explore all these different topics and make sure we come to good conclusions and good diagnoses.
Excellent, excellent. And today, when we talk about tachycardia, we're specifically talking about sinus tachycardia. So we're going to talk about an algorithm for sinus tachycardia. Now, if you read a textbook, like a Harrison's textbook of internal medicine, and you look up the causes of sinus tachycardia, I don't know. I haven't really done that. You'll probably find hundreds, maybe even thousands of causes, because a lot of things can cause sinus tachycardia. But I'm going to give you an algorithm today that's going to at least distill it down to some simple categories that is easy to remember. And yeah, like Eric said, this is a very common reason to be called to the bedside. When I was an internal medicine resident, my critical care attending said sinus tachycardia is the thinking man or woman's rhythm, because so much can be going on. But one other thing I want to make a point about, if your patient's rhythm is chronically atrial fibrillation, right? So this is chronic AFib, not new onset, but chronic AFib. They may also be in atrial fibrillation with a rapid ventricular rate, because that is their underlying rhythm. So essentially, think about this like sinus tachycardia. So I want to be very clear there. We were just talking about this, Eric, weren't we? About doing an episode on rate versus rhythm control and what the newest guidelines suggest about atrial fibrillation.
Yeah, there used to be some talk about rate is better than rhythm, or rhythm and rate are equal. And then there's new research coming out that we probably will talk on in a future episode.
Yeah, we want to get them in rhythm control as soon as we can. So I just want to make that clear. But if your patient does have chronic atrial fibrillation and now they're in rapid ventricular rate, like in the 130s, 140s, think of it like sinus tachycardia. Something is driving this rhythm or rate, this underlying rate to be high, and worrying about the underlying cause, not necessarily the atrial fibrillation at that point, is key. So now let's get back to sinus tachycardia. I just wanted to make that note clear, because people do lose track of what's happening and why the heart rate's up, and they start thinking about, oh no, my patient's in AFib with RVR, when we know they have chronic AFib, and they start doing rate controlling agents when that is not the underlying problem. It's something like sepsis or something else driving it, and you get lost a little bit in that AFib. So that's the only note I want to make on that. Now let's tackle sinus tachycardia. All right, Eric, where do you want to start here?
I want to go just briefly back to that backbone, that oxygen delivery equation, cardiac output with hemoglobin and SaO2.
This is the time to get into it, I think. We talked about not doing it a couple episodes ago, but this is the time, I think, Eric.
Yeah, I agree. Tachycardia basically touches just about every one of these parts of the equation. Every little component is going to be a little bit associated with sinus tachycardia. So, of course, you have the cardiac output, which going back to med school, we know heart rate versus stroke volume. And then, of course, if you have like shock patients with cardiac output problems, you're going to have some heart rate issues that go along with that in most of the shock cases.
Absolutely. So yeah, DO2, Eric's talking about. DO2, oxygen distribution equation, I think is the most important equation in physiology, but specifically in critical care. This is what we're trying to do at the bedside, is improve oxygen delivery to tissue. So let's get into it. Just as Eric said, you got flow basically, and you got oxygen content, O2 content. So flow times O2 content. What specifically do we mean by flow? As Eric said, it's heart rate times your stroke volume. That will give you your flow. That is your cardiac output. That times your oxygen content in the blood, which is your hemoglobin, times your oxygen saturation, plus 0.003 times the PaO2 will give you your O2 content in the blood. Now, you might see some equations with 1.34 times the hemoglobin. Right now, for the purposes of understanding right now, for understanding the point of this equation, don't get too deep into that right now. 1.34, all that means, you might say 1.37, 1.39, but I always think about 1.34. Where that comes from is 1 gram of hemoglobin fully saturated carries 1.34 mLs of oxygen. So we're just going to ignore that number now. I want you to really focus on hemoglobin. You have to have an adequate amount of red blood cells with hemoglobin. That hemoglobin needs to be saturated. And then, to some extent, the partial pressure or the plasma content of oxygen, which is 0.003. So a smaller, but sometimes in some cases, significant amount. So that's the DO2 equation. We're going to look at, specifically looking at the cardiac output and flow here as we look at heart rate, how it pertains to heart rate. Because one of the things we can do to increase oxygen delivery to tissues is increase our heart rate.
And so you have these 5 different, so not 5, let me count, it's 8 different things that can possibly contribute to the increased heart rate. You have this A, B, C, D, E, F, G, H. Sorry, this is almost, feels like half the alphabet right there, but.
Yeah, a lot of letters there, but yeah, not a crazy weird word to remember. I guess it's, if you remember the alphabet up to the letter H, you got our mnemonic here, or at least you'll be well on your way to figuring out at least what the cause is. And sinus tachycardia. Now, this is something I always got called to as a resident. I didn't know this not an equation. I didn't know this mnemonic as a resident. So when I got called to the bedside to go see a patient who was tachycardic, I was always very worried. Many times, I didn't know where to start. Does this ever happen, Eric?
We definitely get called patients' heart rates in the 150s. What do we want to do? What do you want to do? How do you want to fix that?
Just give them metoprolol.
Yeah, you definitely give
channel blocker, right, Eric?
Definitely. You load them on metoprolol, 5 IV Lipressor, and you walk away.
That's right.
I'm kidding. Of course, I'm kidding.
No, we're kidding there. That was just a joke. But it makes us all feel better. We can get the heart rate down, but we got to figure out why the heart rate's up. That's the key.
Yeah, we can't be treating numbers on this one. So the first few ones in this is ABC. Some of these we've talked about, some of these we're going to talk about, but underlying causes, so like hypoxemia, we've talked about in the past. If someone's hypoxemic, they are going to have a bit of a higher elevated heart rate. So if we're thinking that's the issue, go see our first episode and try to do that workup. Now, shock is another one. A lot of patients who are in shock, most of the shocks are associated with an elevated heart rate. Not all of them and not in every stage, but most of them have an elevated heart rate. So we're going to have a different episode devoted more to that.
Yeah, I think we're going to talk about shock next, Eric. But yeah, so we got ABCs. Think of ABCs, airway, breathing, circulations. Let's not recreate any other wheels that we don't need to right now. Everyone knows the ABCs, airways, breathing, circulation. I know some people think of it as CAB, but either way, airway, breathing, circulation. As Eric said, these are something we just talked about, but that's part of my mnemonic. So I think of the ABCs first. So if a patient has hypoxemia, one of the ways if they are hypoxemic and they have low oxygen content in the blood, so as you think of that DO2 equation, their O2 sat is low, or their PaO2 is low, or both are low, most likely. One of the ways to improve oxygen delivery is by increasing the heart rate. So is my patient hypoxemic? That's the first thing I think about. Or like in the second episode, if someone has increased work of breathing, tachypnic, and they're on the verge of respiratory failure, there's going to be high catecholamine, epinephrine surge. That heart rate's going to be up because it really stinks when you can't breathe. So those are my first two. Think about airway and breathing. So if you go to the bedside, you see that patient struggling to breathe, taking short, shallow respirations. For the most part, that heart rate is probably going to be elevated just because they're on the verge of respiratory failure. And also that first episode, when they're hypoxemic, that heart rate is going to be up unless you're blocking it for some reason, but it's going to be up. So those are that's your A and that's your B. And then as Eric said, your C, which is circulatory failure or shock. So ABC, think of that. Again, if you're in shock, and let's say for this case, your stroke volume is down, or there is another reason, we'll get into shock in our next episode, your heart rate's going to go up as compensation to increase your cardiac output. So those are your ABCs right there.
Yeah, and that leaves us next to the D, the drugs.
D is for drugs.
Sometimes this is stuff that we do to the patients, and sometimes this is what patients have done to themselves. So we got to keep in mind that certain drugs like epinephrine, dopamine, and even albuterol can all increase heart rates. And then there's other drugs that patients do take, like cocaine and amphetamines, that can also drive heart rates up as well.
Absolutely.
And then, of course, there's withdrawals from drugs that we have to mind. If someone's on a beta blocker and then they've just abruptly stopped it, sometimes you can have that rebound tachycardia. And there's, of course, lower heart rates, which is more of a bradycardic situation. You can have your calcium channel blockers and your beta blockers that can all contribute to that. The next one, unless you wanted to add on, go ahead.
Absolutely, Eric. D is for drugs, and we talked about things that can cause tachycardia, but also think about drugs that patients are on at home chronically, like Eric mentioned already, calcium channel blockers and calcium channel blockers, but also think about alcohol withdrawal. Also think about, are they on a benzodiazepine or opiate that they're on and we abruptly stopped it? Think about those things. So I always think about withdrawals in there too. That is a common cause of sinus tachycardia that we don't want to miss because those can be very serious. So that's drugs. Now it's A, B, C, D, E.
This is maybe a stretch, erythrocyte depletion. So we're mostly...
Hey, I worked hard to figure out that E, Eric.
Kind of really shoehorn that in. So you got anemia, essentially. So this is your hemoglobin content is low in the blood. And so I think oftentimes this is more of an acute issue, more of a quick drop in hemoglobin as opposed to a compensated, but I don't know what your experience been.
Yeah, go back to the oxygen DO2 equation here, and hemoglobin's part of that. So as the hemoglobin drops, it's not like you can magically give yourself a transfusion, right? So if that drops, most likely abruptly, so there's some kind of acute blood loss, anemia, hemolysis. As your hemoglobin content goes down, one of the ways to increase oxygen to tissues is by increasing the heart rate. We have control over that. So don't forget the E, which is erythrocyte depletion and acute or severe anemia.
And that can be a relatively quick fix, and you can CBC, move on, you can transfuse them, and hopefully you can get that kind of in the immediate term fixed and improved.
Absolutely.
Next one would be fever, F.
Fever, yeah. F, I put fever in there. I think of anything that can increase O2 demands, right? And so there's a lot of things there, but the most common thing that I see at the bedside, practically speaking, is fever. So think about fever, measuring that temperature. That is a common cause of sinus tachycardia. It may also help you figure out maybe something early is happening. Maybe the patient is getting an infection or sepsis. So think about fever in there or anything that increases oxygen demand. So I think of fever. I also think about hyperthyroid states, which are kind of the two most common ones. Of course, there are others, but if you keep those two in mind, at least that one, fever, and hyperthyroid states, another one that can increase oxygen demands, that is going to drive your heart rate up to meet that oxygen demand by increasing your flow. All right, and anything else on that, Eric, or you want to move on to G?
I think it's good to move on for that one. We can go to G, which is our glucose. And my understanding of this one is low glucose causing the patient to be is more this symptoadrenal response.
Yeah. You ever have a low glucose? It's not a pleasant thing. Sometimes you might find your patient altered, but they do. They get an increase in sympathetic surge, epinephrine surge from the adrenal sympathetic response. So you might find a patient who is maybe even diaphoretic, hypoglycemic, their heart rate may be up. Check a glucose, especially if there's maybe some altered mentation as well there. So that's something to think about. Yeah. So good. We're moving pretty fast through this mnemonic.
Yeah, we're hanging at 15 minutes, but let's see. This last one is H, and then this is the holy crap, it hurts. They're in pain. This is a pain-driven sinus tachycardia.
Pain. And Eric, I put this last for a reason. I think it's H is for holy crap, it hurts. This is pain and anxiety. So I put it last. Well, I put it last for two reasons. One, it fit my mnemonic better because that's where I had the H. But the second thing is I don't want people to right away jump to pain and anxiety and medicate a patient for that when there's something that could be more serious underlying, like hypoxemia, early shock, withdrawal from a medication, maybe a severe anemia, maybe an early fever. So pain is real. Anxiety is real in the hospital. So we may have to treat that appropriately. but I don't want you to automatically jump to it. So every circumstance, every situation, I don't want you thinking, let's just give them some benzodiazepines or Haldol or whatever the appropriate treatment is for their pain and anxiety. But think about it. It happens a lot, but think of other causes so we don't miss something very serious for our patient.
Yeah, and that way, again, treating the underlying cause is the common theme here. If you treat the underlying cause, hopefully these things will get better over some period of time. I think some people do worry about someone staying in sinus tach for long periods of time, cardiomyopathy. That's typically takes a lot of time before that can really set in. So treating the underlying cause is probably going to be the key to all of these. And of course, identifying it and applying the right treatment is the key there.
Absolutely. So now when you're called to the bedside and you're worried about, or a nurse is worried about, sinus tachycardia, at least now go through an algorithm in your head. You may get down a primary cause, or you may narrow it down to maybe one or two causes, but it's certainly going to help you more than when I was an intern and I would think about thousands, hundreds of causes and get really confused. Now go through your mnemonic. A, B, C, airway, breathing, circulation, hypoxemia, increased work of breathing, shock. D, think about drugs. Maybe they're on a drug that causes it, or maybe they're withdrawing from a drug. Think about E for erythrocyte depletion or anemia. F is for fever, anything that increased oxygen demands. G, glucose, especially with that sympathoadrenal response, and check a glucose. And holy crap, it hurts. So I really want to give a shout out to Dr. Mark Mazer, one of my first attendings that taught me sinus tachycardia is the thinking person's rhythm. And really to one of my mentors at the University of Pittsburgh, and that's Paul Rogers, who really put this mnemonic in place for me to teach you guys. So thanks to them. And I don't know, Eric, is anything else you want to say on that? Or
this is good. This is, again, don't treat the number, treat the underlying cause, and you'll be in good shape. So I think you nailed it here.
Absolutely. So I think next we're going to tackle a small category called shock in our next episode. We may come to shock a few times and really break down the different causes, but we're going to give you a way to think about shock or hypotension in the next podcast at the bedside with limited data. And then we'll kind of wrap all of these things up together with some cases.
Sounds good.
All right. Thanks, Rebel EM listeners, to another episode of Rebel Crit. Have a great day.